Okay, so my clock turned to noon, so good afternoon. Dr. Donald Jervich here with our phase two of what we call the ECHO Coalition, our Collaborative Action Network, I'm sorry, CAN. And this is a program to consolidate our findings from phase one. So thank you for all the participants for joining us with these efforts to consolidate our learning. And just as a reminder, we're trying to ramp up quality improvement and to use these afternoon sessions as what I call QAPI on the fly, so that we can potentially use these afternoon sessions as your documentation that you are doing QAPI, that you are participating in these programs, and that you have, like I say, the documentation of these events that will contribute towards your overall QAPI plan. So I suppose, in a sense, that if as you look and revise your QAPI plan, you might want to include these ECHO sessions. For those that aren't familiar with ECHO, it's educational for community health organizations is the abbreviation for ECHO. And the whole concept behind ECHO is to do some didactics, but more importantly, to have working sessions so that the participants can ask questions, share ideas. And this is what we're trying to do, is consolidate our findings and our observations. We're focused on COVID and infection control, which includes different components of QAPI. And so as you all may recall, we initially took a vote and we decided to do a social isolation, PIP. And so that's what we're trying to evolve currently. And we're looking for your understanding and your gains that you've achieved through this PIP. As we move through the end of the month, we're going to be looking at another PIP, and we'll take a poll on that. Oh my goodness. Sarah, it looks like you've already got that up and running. So why don't we go ahead and do our poll for our next PIP. Yeah, so this is the topic. And again, we want to do this collectively. So whichever one crops up as the most interested, then that's the one that we'll pursue going forward. And while we're waiting for the poll, I wanted to mention that there's some additional data on vaccination. I think one was from Michelle Lochner that had a report from McKnight News, and they were reporting on two nursing home solutions to vaccine hesitancy. One was which we discussed previously, which was incentivization. And so in this particular case, they incentivized their staff to get vaccinated, and basically it was a generous $1,000, I believe. And so when they got the first vaccine, they were given $100. And then, rather than waiting for the second vaccine, they said that once everybody achieved two vaccine, or both doses, by 75% or more within the facility, staff getting vaccinated, then the $900 bonus would be distributed. So they kind of made it into a group effort. And then there was another nursing home on the East Coast that mandated that staff workers needed to be vaccinated. So that one, so as you might ask, well, which one worked better? And it turned out that they got 90% compliance in both instances. So both the carrot and the stick seemed to work. And I think probably part of the issue that we're feeling the crunch is just, the availability of staffing, and the turnover. So it makes the, how do I want to say, the stick approach a little bit more difficult. But in terms of the continued and persistent education on the vaccine, the important point was that the staff understand that things like vaccines do not affect fertility. They do not affect the placenta, which is another big thing, for pregnant women, and it does not affect pregnancy. And as you may all know, the recent approval for vaccinating 12-year-olds and older now has been approved. All right, so just looking at the poll results here, it looks like Falls is the winner. I don't know if Falls is ever a winner, but thank you for that. I think, with my background in geriatrics, that's something that is near and dear to my heart. So I'll just say at the first outset that just to get you all prepped, is that if you don't have a policy for vitamin D supplementation in your facility as a standing order, that would be one of your first interventions that you might want to think about, because there is evidence that in the nursing home setting, the supplemental vitamin D reduces falls. But I'm chock full of ideas, and I've got a lot of evidence-based medicine that I can share with you on that. So thank you for that survey. So today I just wanted to let you know we're going to review the Institute for Healthcare Improvement curriculum. It's a short video, about 10 minutes. And this is just reviewing some of the risk mitigation strategies for COVID. And then we're going to launch into the QAPI at a glance. This is the CMS Center for Medicare and Medicaid program on QAPI. So we're going to review that with our quality improvement officer. Just in the chat box, wanted to find out if you could put down anything that you learned from your walk rounds. So if you can just type it into the chat box, that would be wonderful. And as a reminder, I think we did the survey where walk rounds typically are done once weekly by most of the facilities. Some of the facilities indicated that they do daily walk rounds, which is pretty good. But again, just having these structured walk rounds are so vital to identifying issues. And, if you've had any barriers to the walk rounds too, that would be good to share, with the group. And we don't have Faye with us today from the state infection control group, but I guess the other question is, do we know, Michelle or Vanessa, as to what the rate of infections are for COVID right now? Before it was about one resident per nursing home. About 2/3 of the nursing home had one resident infected with COVID. I don't know if that's changed this past week or not. Do you guys know?
I haven't looked at the state reports. What I see is coming from NHSN, and I'm usually a week behind on that. And there was only like 3 new infections that were reported last week that I saw. So good. That was good.
Yeah, and I looked yesterday at the state report, and it looked like there was, I think, 23 cases maybe in the state, and it was kind of 2 to 1 as far as 1 resident to 2 staff.
Yeah, that's good. And we have not heard whether the vaccinated staffers had previously, whether whether it was vaccinated or unvaccinated staffers that were COVID positive. They didn't break that down, did they?
No, they don't break that down, but what we've heard from facilities is it's mostly the unvaccinated staff.
Exactly.
And of course, with over 90% of the residents vaccinated, it is quite a few residents that are, when we do have positives, that they had been vaccinated.
Yeah. Well, thanks, Billy, for the comment here that as we're talking about the walk rounds, so as people are transitioning to more socialization, it looks like there's some improved moods. That's wonderful to hear. And be interesting to hear what people's experiences are for the group dining, as to whether you're doing social distancing or what arrangements you've made for that. Have you created more shifts, if you will, for the social dining or not? So I just want to put that bug in your ear. We don't need to talk about it now, but this whole social PPE or emotional PPE, I think is really important as to how, and also one of the discussions I'd like to have with our group here is how we're creating adaptability and resiliency, both amongst staff, residents, and family members. So a lot of times we put that onus on the social work and recreational therapy, but it's not always a what I want to say a facility-wide effort to try to strengthen resiliency. And so we're interested in feedback on that down the road here. So just want to again point that out as a topic of discussion. The other comment here is that we have no positive residents in our facility. Unfortunately, we have one positive staff member who already received their vaccine. Yeah, okay, well, and did that person have symptoms, or was this a asymptomatic screen? So Billy, are you able to, I don't know if you have a microphone to talk or.
Yeah, can you hear me?
Yeah.
Okay, yeah, they had cold symptoms, which actually quite a few of our staff member had cold symptoms, congestion, sore throat. Quite a few of us did. It kind of went through all of our management team. We're all doing rapid tests daily, and she popped positive on the rapid test one day, was negative on her PCR test, and the rapid test the following day was negative. So we're not exactly sure what the deal was, but.
Oh yeah, false negative. Yeah. Okay, yeah. I mean that's a high false negative rate too, and I mean so I'm saying it wrong. False positive rate. So it's like that rapid antigen test is can be 15% false negative, and conversely, its specificity is not real good. It's even worse. It's like 40%. So yeah, yeah, go ahead.
Unfortunately, we were told she had to stay out for the 10 days.
Oh, okay. Well, better to be cautious than not. I mean, I hear what you're saying, and you know, I was having trepidations yesterday in my clinic with one of the staff members who was coughing up a storm, and I'm going like, why are you in clinic? And they said, well, we tested for COVID and we're negative. So whatever else the staff member was passing on, I guess was okay. So it's like kind of, pick your infection du jour these days, so if it's not COVID, good, you're good enough, but people do die from influenza. So yeah, and that would be the other point is, checking for influenza, by the way, in that case, and also for respiratory syncytial virus, which are highly contagious. All right. Well, thanks for sharing all that. Okay, so the other point, in terms of our social isolation, PIP, does anybody have any comments about what have they done anything with that PIP yet, or anything in the documentation that is of concern? So again, if you could just type it in the chat box, that would be wonderful. And I wanted to just also, while you're putting it into the chat box about your social isolation PIP, I wanted to ask our group from the UND ECHO program, how are we doing with the homework submission? And that's part of our reimbursement program, by the way. So I don't know, Casey or Sarah, can you comment about how we're doing with the homework submission?
I don't believe we've received anything new in the last couple of weeks. So we're kind of with the same ones who submitted earlier in the process, but we highly encourage you to still get those into us. And even if it's just a small portion at a time, we'll take it. So. Yeah,
we're not we're not trying to keep the money by any stretch. So if you guys can do some catch up on the homework. So just as a reminder, what we wanted was a root cause analysis. If you use the Fishbone tool, for social isolation, there was the Quality Health Associates documentation for the PIP and for the Plan, Do, Study, Act cycle. So if you can complete those forms, that would be great. And if you actually want a copy of those, of the ones that we have received, we can share those with you, and you can just basically put your name, your facility's name on it, and send it right on back to us, and we'll count that. So, like I say, we're pretty generous. Michelle, did you want to say anything about that?
And later on in the session, I do have another example of a PDSA document that I'll share that we can also put up on there. That's maybe a little bit easier. So,
good.
Something that the Center for Rural Health was using in some projects I was doing with them. So we'll share those.
Okay. Yeah. And the homework, by the way, is intended to kind of keep the wheel moving on this. And so what we're hoping is that we do the session, at noon, and then maybe just think about whether, at 1 o'clock from 1 to 1:30 or something, that you get the homework done, just while it's fresh in your mind, just get it done. And then you can either submit it at the same time or, at the end of the day or whatever. I mean, we don't want to impose any scheduling kind of thing, but, just kind of catch the wave when you can is my thought. So, all right. So we can go ahead and move on to the next video here. Yeah. So why don't you go ahead and show that? Thank you.
Hello, and welcome to today's presentation on post-vaccination, on strategies for risk mitigation and adherence to core principles of COVID-19 infection prevention. Focusing in on risk mitigation and adherence to core principles of COVID-19 infection prevention is very, very important for nursing homes today. According to CDC and CMS, focusing in on that risk mitigation and those best practices will reduce the risk of COVID-19 transmission. These are not new to all of us as providers. However, they are essential to review, update, and incorporate into our overall post-vaccination processes.
Strategies are needed by long-term care centers to appropriately evaluate and to manage post-vaccination processes to reduce the risk of COVID-19 spread among residents and staff, as well as visitors. Having that base, that solid infection prevention and control plan will be a key to risk mitigation. There are so many risks associated with not having a solid post-vaccination process, visitation, and good infection prevention and control principles. There are risks to residents, such as post-vaccination systemic signs and symptoms, social isolation, depression, cognitive impairment, and more. Risks to visitors could be exposure and infection. Risks to staff, also exposure and infection, but also the action that they may have if they don't follow proper policies and procedures from leadership. Nursing home risks would include things such as quality and compliance, legal issues, reputation, and more.
So let's review the core principles of COVID-19 infection prevention. While these, again, are not new to any of us, they are essential processes for risk mitigation and should be adhered to. So the first one, again, we see here is screening, and that's screening of all who enter the facility for signs and symptoms of COVID-19. That's including doing temperature checks, questions about, their exposure, observations of signs and symptoms. And then also part of that process is the denial of entry for those who have signs and symptoms or those who have had close contact with someone with COVID-19 infection in the prior 14 days, regardless of the visitor's vaccination status. Hand hygiene, again, core principle. The use of alcohol-based hand rub is preferred, as we know. Face coverings or the mask, that's covering of the mouth and nose. So the PPE for staff per guidance, our residents and visitors. And again, social or physical distancing at least 6 feet between persons.
Additional core principles include that instructional signage throughout the facility and proper visitation education on COVID-19 signs and symptoms, infection control precautions, facility practices such as face coverings or masks, and they need to be in specified entries, exits, and routes on designated areas, also to include hand hygiene. We also have to remember that cleaning and disinfecting those high frequently touched areas in the facility very often, and designated visitation areas after each visit. Also, appropriate staff use of PPE, which we've covered in detail in another module, and then effective cohorting of residents. Resident placement is a key process that must be followed in accordance to CDC, CMS, state, and local health department guidance. Resident and staff testing also needs to be conducted as required in the CDC and CMS guidance. The next few slides, we are going to discuss some of the core principles of COVID-19 infection prevention.
And looking at these core principles, we wanted to focus in on a couple of the key ones that are part of our discussion today. And the first one here is screening. When implementing best practice post-vaccination protocols specifically related to visitation, screening of all who enter the facility for signs and symptoms of COVID-19, and also including that we're looking at the denial of those who have signs and symptoms or those who've had close contact or exposure with someone with COVID-19 infection in the last 14 days, regardless of the vaccination status, is a key process. And we have to make sure our process has been updated to the current guidance, looking at vaccinated, non-vaccinated individuals, as well as the key screening protocols. So if you're not performing active screening, you will not be able to deny entrance to visitors, staff, or others who have symptoms consistent with COVID-19 or discuss the close contact and exposure to someone with COVID-19 infection in the past 14 days. While CDC has specific guidance in place, please make sure that you discuss in this cohort with state-specific guidance as it relates to active screening processes.
With mitigation, hand washing still remains the #1 preventative method in the spread of infection. Having a robust process for hand hygiene will be instrumental as a core principle for infection prevention and control. We know that those elements include having good policies and procedures on hand washing with soap and water for at least 20 seconds if hands are visibly soiled, alcohol-based hand sanitizer, which is that 60 to 95% alcohol. The CDC indicates that unless hands are visibly soiled, an alcohol-based hand rub is preferred over soap and water in most clinical conditions or situations. And then supplies. We want to identify what is our process for inventory, delivery on use areas, as well as signage. And then, of course, those process surveillance audits, which are those audits that look at compliance with hand hygiene to be able to identify compliance and gaps in the process in order to put into place quality improvement actions.
Social distancing, again, is another one that we want to be and bring up front for all of us to look at. We know that social distancing, which is also called physical distancing, is keeping that safe space of at least 6 feet from other people in both indoor and outdoor spaces. This risk mitigation strategy is still in place for all leadership, staff, residents, and visitors. Combined with other core principles of COVID-19 infection prevention, it can really, truly reduce the spread of COVID-19. There's another area in which infection preventionists and other key interdisciplinary team members can monitor in order to identify any opportunities for reducing the risk of spread of COVID-19. So staff, all of our staff, as well as ourselves as leaders, have key roles and responsibility related to physical or social distancing. These practices, again, like we indicated, are still in place. So let's review some of the key areas to remember as part of this core principles of COVID-19 infection prevention and mitigation strategies. So physical distancing, again, a reminder for all of us that physical distancing on the nursing units, at the nursing station. Are we utilizing and still putting in place physical distancing in meetings and in the conference rooms, during training, during break times? Are we looking at, when we're doing our surveillance audits, looking at observation of residents? Again, observation during visitation in alignment with the current policies and procedures and guidance. Visitors must be able to adhere to core principles, including infection prevention and control practices, and staff will truly be providing monitoring for those who may have difficulty adhering to those core principles.
Additional areas that will reduce the risk of COVID-19 include appropriate use of PPE by staff, face coverings for residents and visitors, proper cleaning and disinfection, testing per guidance, and more. A solid infection prevention and control program with good process surveillance and follow-up action will be essential for risk mitigation. Surveillance is essential to an effective post-vaccination plan for your organization. One way is through process surveillance audits. Process surveillance reviews compliance with your process or your policies and procedures to be able to identify both compliance as well as gaps or opportunities for improvement in order to put into quality improvement actions. By definition, process surveillance is the review of practices by staff directly related to resident care. In essence, process surveillance really will identify if the staff are compliant with best practice approaches for infection control that are outlined in the policies and procedures. The question is, do your policies work? Process surveillance can determine if the facility reduces exposure to potential infection source, proper hand hygiene, appropriate PPE use, proper cleaning and disinfecting of equipment, proper screening, and more. Examples may include active screening audits, hand hygiene audits, PPE use audits, cleaning and disinfection audits, and more.
So in summary, we reviewed the strategies for risk mitigation and adherence to core principles of COVID-19 infection as part of your post-vaccination practices. So again, focusing in on risk mitigation, the risk to your residents, risk to staff, risk to families, visitors, and vendors, as well as the risk to the overall organization. Also, the adherence to those core principles of COVID-19 infection prevention, which included, that we discussed today, the screening and active screening for all who enter the facility, hand hygiene, face covering or mask, social and physical distancing. And again, as we discussed, the signage and cleaning and disinfection, PPE use, effective cohorting and testing. The need for surveillance and monitoring and improvement activities, as well as education, is very, very important and part of this process. So again, it's very important as leaders, when we look at our policies and procedures and our practices within our organization, we need to consider those strategies for risk mitigation, as well as the overall adherence to core principles of COVID-19 infection prevention in order to reduce the spread of COVID-19 within our settings. We want to thank you again today for attending this presentation on post-vaccination practices.
Great, thank you. So we'll move shortly into our quality improvement experts, but before we do so, I just made a request in the chat box that as the communal dining resumes and group activities resumes, I was just wondering if you could report from your facility any positive comments or what people have said, either from staff or residents regarding the resumption of some semblance of normalcy here. So that would be great if you just have some nice phrases, joy of the moment observations. But I also wanted to share with you one of my observations that, and for me, when I go to my clinic, I'm pretty sure everybody's vaccinated in the clinic, but I'm not absolutely sure. And yet when I go into, we have work rooms. So I guess they would be similar to workstations in a nursing facility. And when people are at their workstation, they take their masks off. And I'm not in agreement with that. And I'm just wondering what, if you've reflected on your policies, given the fact that there's such a wide range of vaccinated and unvaccinated individuals. We've had facilities where staff are 30% vaccinated on up to other staff being up to 92% vaccinated. And so that makes me wonder as to whether you've require everybody to wear masks in the break rooms, for example, or do you have a separate break room for the vaccinated staff members and another break room for the unvaccinated? You know, do you separate based upon vaccination status? I don't know if anybody has a comment about that. You can, if you don't mind unmuting yourself and you have a microphone that to let us know if you've addressed that as part of your policy or not. I like Billy's comment about hearing the laughter for everybody. It's sort of like a hockey game, right? You know, they've got all the crowd cheering the players on. There's no crowd. So maybe piped in laughter might be a solution here as we move along. Yeah, that's good. Thank you. Thanks, Andy, for the vaccinated staff can dine together. Perfect. And the same with residents. Yeah. So you are using the vaccination status as, you know, and it would be interesting and something to think about, that whether that's a motivating factor for the unvaccinated staff to become vaccinated, that they maybe the social draw might be a motivating factor. And it would be great if you kind of keep your eyes and ears open for that possibility. That is, if you see a little bit of traction on the unvaccinated staffers becoming vaccinated, as to whether that social, you know, I don't want to call it social pressure, but the, I want to say the positive effects of socialization might have. All right, so some good thoughts there, and thank you for sharing those in the chat box. Yeah, so I appreciate those comments there. All right, so why don't we move on, Michelle and Kelly, I'll hand it off to you here for the quality improvement portion of this session.
Sure. And still, anybody that wants to add in the chat, or if you want to say anything, feel free to just unmute and interrupt, because we really want to hear from you. And with saying that, I'm going to move on to our step 9 in the QAPI at a glance, which is on prioritizing your quality opportunities and chartering for PIPs. That prioritizing for improvement is a key step in processing your data into action. As you continue to implement QAPI, you and your team are going to prioritize opportunities for intensive improvement work, looking at problems versus opportunities, and this often requires a lot of discussion. For what's making the most noise that we need to address, plus being able to identify some opportunities that we could work on together. Choose those problems that you think are most important. Consider again what we mentioned last time, that high risk, high frequency, and or problem prone areas of concern. Remember to take a look at those problems that affect the psychosocial well-being of your residents, as well as their ability to exercise choice. Because this is an area we often get we have a lot of discussion back and forth. This is where the ombudsman gets brought in sometimes. Trying to keep that in the forefront of your mind might avoid some of those issues. Consider which problems will become the focus of a PIP. As I wrote up on this slide, not everything needs to be a PIP, and that might be part of what is daunting when it comes to QAPI, that you think that everything we're working on we have to write out in this big long form, and that's not the case. If you identify a problem, it needs attention, usually from more than one person, but that doesn't mean that it always requires a PIP. Sometimes, issues can be worked out by just assigning 1 or 2 people to address it, or as directed by leadership. But some of those bigger, more intensive problems, we do really need to have the data and that process of the Plan, Do, Study, Act to help us get through that, to make a real quality improvement. Next slide. So a common question is, what is the most important to focus on first? I'm sharing this document here that was actually created in our last scope of work by the quality improvement organizations at large. This is a change package that you can see addresses all-cause harm prevention in nursing homes. What this was is CMS and the QIOs actually went out to 9 nursing homes that are identified as the high, or were at that time, the high performing nursing homes, the highest performers in the country, to identify themes and best practices that they could share and spread to everybody else. And especially focusing on the all-cause harm for residents. It's a great document. We've got it posted on our site. Plus, even if you just type in QIO change package into Google, you should be able to bring it up, or just ask, because it's got lots of great stuff in it. But what I'm pulling out for today is this Appendix A that provides just a document of some ideas of where you might want to start. Some of the topics that they have listed here are number 1, staffing, knowing your residents and including them in their care plans, looking at how to address gaps in care, promoting excellent multidisciplinary teamwork. There's an area on leadership engagement. There's a section on working to ensure excellent, competent, available, continuous care on site, which I think is a great focus area. But this just gives some ideas and some thought processes. And if you can see that number 1 there, there's the A, B, C, D under there. And I want to just stress one more time that QAPI work does not mean work on all of these things at once. If you're looking at working on staffing, maybe just pick one, pick D, focus on staff development. That's what we're going to be looking at. Take a look at that. You could even break it down even further, but you want to start small, trial your interventions, measure your success, tweak your efforts, measure again and tweak again until you can have some success and demonstrate with data and also with happy residents and staff. Next slide. When I look at my notes, I really have a theme going here. Again, we want to discourage you from doing everything all at once. That's my theme for the week. But that's really what prioritizing is. You're prioritizing opportunities according to what's most pressing in your facility, and consider where your staff is in their QAPI knowledge and the journey when choosing how to focus your efforts. Start with that as leadership. Then we have, this is another tool that CMS has developed to assist in choosing which potential areas for improvement are the highest priority based on the needs of your residents and of your organization. What it is, I don't know how well you can see all the white font on the blue, but along the left, you list your potential areas for improvement, and then you do a ranking with these areas of prevalence, risk, cost, relevance, responsiveness, feasibility, and continuity. And you go through these areas and score them according to this metric here of very low to very high, which of course is very subjective, but that's why it means that you need to have your QAPI team and your leadership looking at this together. It can't be one person just deciding whether this is important or not. This has to be a joint decision, and bring in any opinions, bring in your residents, bring in family members when you're exploring your priorities. And thank you, Casey, for sticking the links up there in the chat. Next slide. This section also talks about charters. CMS uses the word charter on purpose, because they want it to be more than a casual effort, this performance improvement project. It entails a specific written mission to look into a problem area. And I know that this is kind of an area that gets kind of glossed over. I'm guilty of that as well, not enforcing that and pushing this area. But the whole point of it is this makes it more real, and will help you, it's a contract that you're putting out there to make it, to show that it's really an important area we need to be working on. this is a worksheet that that CMS has developed as well for doing the charter. In doing some research for today, I found an article called Top 10 Problems Encountered by Quality Improvement Teams, authored by Dr. John Moran, who is the Senior Quality Advisor for the Public Health Foundation. And one of those top 10 problems was that many teams are simply started by management with no formal direction and are left to find their own way. And a familiar statement from that work is, we think this is what management wanted. What a team charter does is it provides you some detail to give you the direction that the team needs to be going to be successful in tackling the task. You have some direction from leadership. They're putting down, this is what our goal needs to be. Then we need to figure out how to do it, but we're starting with the direction from leadership. Too often what happens is that teams are just told this is a problem, and they spend so much time and effort just trying to figure out what it is they're supposed to do, where a well-developed team charter can help increase your buy-in and maturity, since when you fill it out, it answers a lot of those questions of what is the issue that we're supposed to be looking at. I know that it sometimes might seem like an extra step that adds busy work to the process. But again, not all issues need to be addressed by a PIP. We're not doing this for everything. It's only certain problem areas that require that intensive deep dive to make quality improvement efforts that demand an official PIP effort. Charting implies that the team has been entrusted with the mission and that it's going to report back to the steering committee, and it makes it more formal and means that your team and their supervisors all must take this seriously. All right, so the next slide, we're gonna go into our social isolation PIP. Please, if you have any questions on those quality improvement tools and our next steps, just throw them into chat. And
I'll jump in for just a quick 2 seconds.
Please do, Kelly.
Thanks for sharing that change package. I think that's a great tool for you all to reference as you're trying to figure out where to start and what areas to focus on. And it brought to mind a conversation I had with another facility earlier today that they are a 5-star facility, and they're like, I don't have any COVID cases. I'm a 5-star facility. I've got no infection control tags. I haven't got tags period in the past 3 years. So why do I need to work on things? Where does it start? And I think too often, and I can say in my experience in the nursing home, I described myself as a fireman, and all I did was walk around and put fires out all day. Well, what I didn't realize, I don't think either when I was in the facility, is that if I could find what was igniting these fires and truly correct a system, then you wouldn't be running around putting fires out all day. So I really think you've got to take a step back and try to look at it from a bigger picture. It's not that you have UTIs on the 200 wing rapid, but why do you have those UTIs on the 200 wing, and how can we correct that system or that gap in order to improve more than just the UTIs on the 200 wing, because it could be something deeper down as being the issue. So that just brought to mind to me, and I wanted to say that. And also the charter is really just a great tool to hold you accountable. And to keep yourself on task. I was always a checklist person. I still am a checklist person. And I feel like that kind of gives you that groundwork to start moving through that process.
Thank you so much, Kelly. I see Dr. Jervich had put in there that can the QAPI director delegate or assign the job of project manager to one or more CNAs? And I say definitely yes, especially when we're looking at areas that are, are specific resident care. And I mean, they know the flow of your building. They know what times things are impacted and what the residents really want and need. So I'd say yes, definitely. Okay, we'll go to the next slide. This is just another action plan. This is not a full PIP document. This is just more, it looks like a PDSA kind of a document that as I said, Center for Rural Health. I was using this when I was working with Jody Ward on a project. And so it's not as complete as all the elements in some of the other tools, but maybe it doesn't need to be. Maybe you need something really simple and basic like this to just not a lot of reading. It's very clear. What is our next step going to be? Who's in charge? What is the date we need to get it done by, and how are we measuring it? So just another document. If you feel like this is something you want to use, we'll put it up on the website. And next slide, I'm going to turn it over to Allison from Rosewood to talk about where they are with their PDSA process.
Hi, can you hear me?
Yes. Hi, Allison.
Hi. So yeah, just to review our goal for our PIP was that we would get the percentage of residents who reported a 3 or a 4 to question number 1, which was how often do you lack companionship, down to 25% or less. So we had met on Tuesday and reviewed some of the specific interventions that we are going to implement with some of those residents that reported a lack of companionship. And so our care managers who are assigned to the unit for those residents have implemented those interventions specific to those residents. Some examples of those is one resident who attends an MS support group in the community is resuming that now with having been vaccinated and being able to be in a group setting. Visits from our spiritual services, our deacon here, just doing more one-on-one visits with some of those residents. Getting together a couple of residents to play cards. Visits outside in the courtyard now that the weather is a little bit nicer. And then also trying to encourage family visits outdoors. There have been some families that haven't wanted to come into the facility for visits. So that's another option for them. Going to church services, dining in the main dining room. Now we've had the change in the communal dining, so we can have more residents in our dining room. Some of whom did go prior to COVID and some who are new who have never been to the main dining room for communal dining. So those are some of the individual interventions that we are implementing. And then the other plan that we discussed is to implement 2 group activities for the whole building, but including those 12 residents who we've interviewed. So one of them is going to be an afternoon movie with popcorn and root beer once a week. And then an evening activity is a tour of the United States. So they're putting together a PowerPoint presentation. I'm going to choose a couple of states to visit once a week, and they'll have a snack or a food item that's associated with that particular state or region that they're visiting. So kind of a couple good ways to get residents together, visiting with each other, developing maybe some relationships to hopefully help with that companionship piece. So we met on the 11th, and we're going to give it 1 month to trial those activities, interventions, and then we will repeat our interview with those 12 residents to see if we've had an improvement in that number. So that's kind of where we're at. I guess it'll be a little bit of a standstill for the next month as far as any updates, just as we're getting those things put into place. So.
And that's great. Thank you so much, Allison, for sharing that. And, you know, I just looking at that last one that you put, the implement afternoon movie with popcorn and root beer. And, you know, part of what we're looking at as you are able to do that is just collecting any evidence of what do they like and what do they not like for this activity. Are you getting complaints that nobody likes root beer, or that the popcorn's too salty, or they don't like your choice of movies, or anything like that? And that's how you tweak it to get to, so we can try to get to that success. So.
And we did talk about too, with those 12 residents specifically, just looking at, what their participation level is. So the care managers are going to kind of focus on those people and monitor them during the activities to see how interactive they are, if they seem to be enjoying it during the time, and just kind of take some little notes to bring back to our group. Not that it has to be, documented in their chart or anything, but just for us to kind of track how they're doing with those activities too.
That's great. And also that, that group of 12 kind of becomes your pilot too of, what can we roll out more? You don't have to interview every single person in your huge facility to see, do they like it, but you can kind of extract data from this group. So